This week on The Great Equalizer, we're in studio for the second installment of TGE Talks Menopause to chat about the concept of normal in perimenopause.
We're also getting up close and personal about our own perimenopausal journeys with expert guest Dr. Louisa Albertyn,
who, it just so happens, is the very woman caring for my middle-aged body
and mine
as we navigate this new normal. Welcome, Dr. Louisa.
Thank you, ladies. Thank you for having me. It's an honor.
It's a great pleasure to have you here. And I don't feel like I'm so much in the hot seat, but you know a lot about us.
Yes.
This is very...
It is
patient confidentiality, don't worry.
Between us and all of our listeners.
Yes.
You won't be the one sharing, and we'll be the one sharing our personal journey. So there's no overstep here.
Okay, us chronic oversharers are used to it. You know?
Exactly.
Dr. Louisa, it's such a pleasure, as we mentioned. You're a GP here in Johannesburg, the great Gauteng, but nothing about your approach is generalized. Mm-hmm. According to your bio, you believe in a personalized approach to health and healing. You've got a very special interest in women's health, sexual health, and mental health. You're also an accredited My Sexual Health practitioner. You work in conjunction with the MSH team in Johannesburg. You offer a safe space for those with sexual health needs. This includes the shifts that we've seen hormonally over the years, which is why we both landed up in your office at some point in time over the last year or so. I'm really curious, what about your journey as a doctor prompted you to get My Sexual Health accreditation to become involved in the sexual health needs of women as a GP?
Thank you for the question. And since we're all oversharing, I'm also going to overshare today.
Good, do it.
But I do believe that we're joking about oversharing, but in doing that, we just normalize sexual health and women's health and break stigmas. So how I got into sexual health is no class in university made me want to go in sexual health. In actual fact, our class was called the pensioners because we didn't ask any questions. We were just sitting there in the 2 sexual health classes we had.
Oh my gosh.
And so then actually when I got married, I struggled with vaginismus, so painful sexual intercourse.
Oh, wow.
And I landed up seeing Dr. Louisa Albertyn, which was also part of the My Sexual Health team. And through seeing how she helped me and the whole team of physio, I also saw a physiotherapist, pelvic floor physiotherapist. I saw that My Sexual Health actually offers training online. So you cannot specialize in sexology in South Africa. Dr. Elna Rudolph, the head of My Sexual Health, went to study that in Australia. So she is a sexologist, where I'm a general practitioner with a special interest in sexology. So through My Sexual Health, I then started with my training, and with all the accreditations, now I'm working in the Johannesburg My Sexual Health licensed practice.
Okay.
Well, we are so grateful.
I was just about to say, and selfishly, I'm very grateful.
What a godsend. So Charlene saw you before I did, but we both were kind of flailing in our health journeys for different reasons. Charlene, I don't know if you want to start. What brought you to the offices of Dr. Albertyn? Because, you know, this is all part of our kind of as we age journey. And I do think that there are some parallels in our experiences, albeit may we reveal to our audience, overshare that. I know you're going to be shocked by this, guys. Charlene's 5 years older than what I am.
You're being ridiculous.
It's a shock to the system, I know. Let's just take a moment.
Oh, stop it.
But you did experience some parallel symptoms.
Yeah.
Before I did.
Yes.
You've been on a journey. What brought you to the offices of Dr. Albertyn?
I have to just say that it's actually ridiculous because when I started like thinking through the list of ailments, and it's not ailments because you're not sick, you're just not yourself, and it's things that you can easily ignore. But the thing that pushed it over the edge for me was that I had no libido. And out of everything else that was going on for me, and I can run through the list of those things to share with our listeners, but it was the no libido that was a problem for me. And not because my marriage was suffering or anything like that. I felt that's not normal for me. I don't like feeling that feeling. And then coupled with that was I felt really depro all the time, most of the time. And then when it was time for my period to come, it was even worse. And the worrying thing about that was that I was on an antidepressant. So I went to my GP who prescribed my antidepressant, and I was like, Doc, can this antidepressant potentially be affecting my libido? Because I don't know what's going on, but this is not normal for me, A. And B, I don't know if the dosage is right because I'm feeling really dark some days. He asked all the right questions, was a male doctor. He's still our family GP for my husband and my kids. I absolutely adore him. He's very helpful. And he actually did say, let's do some bloods and check your hormones, which kudos to him, because I mean, I don't know if most doctors would do that. So he did send me for some blood tests. The blood tests came back normal. Okay. But, and he said, and he consulted with a psychiatrist on the antidepressant, and he gave me a different one. And so on I went. Almost a year later, I was still feeling pretty much the same. It was still the same thing. And I was talking to Sam about it. And I was like, I don't know that this is normal. Who do I go and see? Do I see my gynecologist? If it's hormone related, if it said my hormones were normal, so do I go see an endocrinologist? I don't know. And because the libido thing was still lingering, and we had years ago interviewed Dr. Elna Rudolph on the show, and we follow my sexual health on social media, and Sam was actually saying, maybe we must chat to Alna, find out if she knows, if in her network of doctors, if there's someone that can help you. So I went online, reached out to my sexual health, and it found me Dr. Louisa Albertyn, who was in my area. And that's how I landed up in your office. And so we looked at the bloods that the doctor had previously taken. And even though they were somewhere within a normal range, some of the hormones were on the higher end of normal, and so some were on the lower end of normal. And maybe you can shed some light on that for us, Louisa, about how you read those things and what is normal. We'll get into the what is normal, but it turned out it wasn't really normal, because if I was feeling these, and you can correct me if I'm wrong, if I was feeling these symptoms or these things that were not right, then my hormones are not normal. So you sent me to do a whole batch of more tests, and then they came back quite abnormal.
Yes. What did that look like?
So I think what is important, I think when I first saw you, I saw your estrogen was actually very low.
Yes.
And that is very important to know, that in perimenopause, the hormones fluctuate a lot. So best time for women to do the female hormones is within the first 5 days of being on a period. So it's important when you went for the blood test.
So those blood tests,
to interpret it
yes,
in the right time of your cycle.
So the first ones I did, it was a random time.
Yes.
He sent me for the test, but the timing wasn't done right. Yes.
Well, yeah, or maybe...
Well, not right.
Yeah,
but
just interpret it of when in your cycle it was done. But also, and also, of course, if you're on a pill, it will impact those blood test results. So... with you specifically, what we saw is that it was very low when I looked back at his results, and then when we did it again, it showed you were estrogen dominant.
it was a skyrocket.
So because in perimenopause, your ovaries, every woman is born with a certain amount of eggs in the ovaries. So when they're getting to the end of their I can say they're getting finished.
Yes,
then
they're running out.
Yes, your ovaries send mixed signal to the brain, and the pituitary hormones then stimulate the ovaries. Make more estrogen or less progesterone, because now I'm ovulating, now I'm not ovulating, and it just goes all over the place. And that is also the reason why you can start with all the symptoms, which I think we'll discuss later.
Yes. Okay.
So it's a fluctuation of hormones.
Yes, it's not that it's not that, so that's why it's not like they're, if you're looking at them in a range, it depends where in your cycle you're taking the tests, A, and B, what is normal for you. And also you have to look at estrogen and progesterone and testosterone together.
Yes.
You can't look at them in isolation. Am I right?
Yes. You look at estrogen and progesterone in a ratio to see if you're dominant, and testosterone not so much in a ratio, but obviously with the symptom that you presented, low libido, I will check your testosterone.
The testosterone. Okay. And you, Sam?
I experienced...
Was scared to death because Charlene was going crazy.
Charlene was going crazy. And I needed to talk to Dr. Louisa to be like, what the fuck? What about Charlene? About Charlene. This is an intervention. I'm joking. I very selfishly had a host of symptoms, which I've actually pulled up because I wrote them down for my gynecologist that I went to see initially. Because as we do, I'm 5 years postpartum with my last born, my second born. And that's what you know. I had spoken to my gynae just in passing. Maybe I had brought my kids, my GP, just in bringing my kids in, or, dealing with a UTI or something. But she said, I think with what you're struggling with, better to go see your gynae. And I'm going to go on record here, not to name and shame, because I actually really love my gynae, but to say that I do think, in my experience, there's a disconnect with obstetricians and gynecologists. And this is really a generalization, but I think that the focus is on baby making and birth. And
as opposed to women's health from the reproductive system or planning right through to post-reproductive care.
Post-reproductive care. Even, it's become a trope almost among women that at your 6-week checkup postpartum, your gynecologist goes, okay, you're good to go for sex. That's the number one concern. And women for decades have been saying that is not my concern. So let me tell you, at age 38, and funnily, this is why I mention our age gap, because 5 years ago, not all of these, but you had similar concerns in not feeling yourself. So I think in my experience, anecdotally, your shift started way before. Similar time.
Yes, similar time to you.
To me.
Started way before I actually addressed it and landed up in the doctor's room. 36,
37, 38. This is assuming you've had kids, which we can't assume for everybody. Assuming you've had children and you are postpartum. Really, it is a generalization. But even in my friends who are now 37, 38 and haven't had children, they're now seeking out sexual health specialists to deal with varying symptoms in changing periods and not feeling themselves. So what prompted me ultimately to make an appointment with my gynecologist initially was my husband saying, it's not because I can't handle you, it's because I can see that you are only yourself 3 days out of the month. And that is
this is familiar.
That is what you told me when you were 38 and I was blissfully 32, 33, going like, I don't know what Charlene's talking about. I'm still making babies.
All the podcasts in those 3 days of the month. When you felt good.
I was in my earlier 30s and not really relating to those shifts. You are a very passionate person and you feel your feelings a lot, and I'm like, maybe it's just that. Until I get there and I'm feeling very low, especially 9 to 10 days before my period, and vaginal dryness, itch and discomfort. I'm really getting up close and personal here. Labial cysts, hormonal acne for almost all the years postpartum with my second. I just had the worst hormonal acne, which got really bad during a seasonal change and got really bad before my period. Dermatitis, eczema, as in all over my scalp and head. Again, I say depression and rage. The rage was a lot it still is, but it's a lot better now. Basically, I had one good week in a month. I experienced extreme fatigue, painful ovulation, early ovulation, nausea and pregnancy symptoms throughout. This is all the symptoms I brought to you eventually. Hair loss. And yeah, I think those are, I mean, it was a long list of symptoms that I took to my gynecologist, and she put it down to PMDD, which I think we need to explain what PMDD is. Do you want to go there? Because I had to explain it to Charlene, but I had to look it up. So let me not look it up.
Yeah, if I miss anything, you're welcome to add what you read. But premenstrual depressive disorder is, let me compare it to PMS, which is premenstrual syndrome. So with PMS, I can say it is normal symptoms to feel before your period, bloating, maybe you have cravings.
Cravings.
And fatigue.
Bit of mood swings.
Irritability, premenstrual syndrome, right. But once those symptoms become debilitating, in other words, it's really, I've seen women that they can't get out of bed, they're so depressed, they feel physically sick, then we're looking more at PMDD. So basically it's those symptoms, but just it is really debilitating and affecting your functioning, your day-to-day living.
Oh, that's when it becomes a disorder as opposed to, because things are not in order. They're not right.
Yes.
It's outside of the normal symptoms you should be experiencing.
Yes. And obviously then you only feel like that before your period. And once your period starts, you usually start to feel better.
So if I can flag the difference between the treatments is my diagnosis was the same between my gynecologist and seeing you as a sexual health specialist or a GP with a special interest in sexual health. And the difference for me was my gynecologist said, okay, Sam, you have PMDD. I'm prescribing you the pill. This is what I recommend. And she recommended a pill called Clara. And I said, okay, can we not take bloods? And she said, no, why? So I said, I'm not on any medication at the moment. I'm not on antidepressants. I'm only taking supplements. I want a base. I'm a journalist. Maybe it's an occupational hazard. I want a baseline for what my blood looks like. Now, I want to make sure nothing's out of whack in terms of my hormones. I just want all the data. I want all that information on record. And then a year from now, when I've been on that pill, if it works out for me, I want to take bloods again and see. I just want to be on top of what is going inside of my body and what's going on inside of my body. And my gynecologist just did not listen to me and did not acknowledge that is what I wanted. She poo-pooed it almost and said, you don't need blood tests. If you really want blood tests, then I guess. And then I think she only ticked off blood tests for the test where you are with how many eggs you have left, your viability, right?
Yes.
What is that?
Your AMH.
Yeah. So I think it was only that. I stand to be corrected, but that's really not the crux of the story. When I just didn't, I had that. Okay, I have PMDD, that tracks for me, but I still don't know what's happening inside of my body. I don't know what my hormones look like. And I want to know because I can feel that there's a shift in that. I can see that there's a shift in that. So I then did exactly the same thing, went through my sexual health, found you as a practitioner, but then we have a lot of questions that we need to fill out. Like it's a big questionnaire that you need to spend a lot of time with. And there is a huge focus on your sexual health and I'm not just talking about libido, but what was key for me is that there's a question there that differentiates between libido and desire. And in answering that, I was like, you can have desire, but not libido. And we will get into it in the next episode of the series. We're going to be talking about sex in detail. However, that for me was like, yes, I feel a little more seen. And then we're talking about vaginal dryness and we're talking about hair loss and that questionnaire is just so comprehensive. And it worries me that I'm throwing a question out at you now that is not planned. So I'm kind of putting you in the hot seat. But it worries me that our gynecologists or our OBGYNs are not doing the same thing. What is your take on that?
Listen, we actually had this discussion at our My Sexual Health meeting this morning, or not a discussion, it's Dr. Alna just said that as a, in varsity, we wish that there's just more education on sexual health.
I was just going to say
Because
to you, is it that you
there
don't
isn't.
get taught that? Because
Yes.
I watched another a podcast, off mic beforehand, I mentioned to you there's another women's sexual health
Yes.
and menopause specialist in the States that I follow. And she's an OBGYN, and she says that in medical school, you do not get taught these things.
Yes.
She's a woman and she specializes in this field, and you just do not get taught it.
Yeah. Things are slowly changing. I think as we're breaking down the stigma of just talking about sex, things are changing, and sexual health is a big field. But our class was literally, hello, do you have any questions? And we were taught like weird things, like that I'm not using in practice today.
Yes.
So, to be honest, if it wasn't for my personal journey, look, I was always intrigued because whether you're a GP, a gynae, a urologist, an endocrinologist, sexual health will always be part of a human. And that is why I love being a GP, because I can look at someone holistically. Whereas maybe a super specialist or a specialist, that is their field,
You
and
hone
that is
in
what they focus
that
on.
particular area.
Yes.
Only, yes.
And it's not wrong. We all need each other.
yes.
But I also think it is important, you know, in the days and the time and day we live in today, people, but let's talk women today. They are educated. They're going to come and see me and say, I've already researched this pill, but like that's where you came and see me. In the end, I didn't change what was prescribed for you, but we sat for 30 minutes and I basically educated you. That was our consultation.
And I must say, I felt seen in that it wasn't just you have PMDD, here's a pill for it. You looked at me and I said, okay, but I suppose it's normal. And you said, no, Sam, you know what? It's affecting your quality of life. And don't forget about your husband and your kids. It's affecting your quality of life. And I get emotional thinking about it, because how many of us women care enough about ourselves to prioritize that?
I also feel emotional when you mention that. I feel tearful because you said the same thing to me. You said, Charlene, you don't have to live like this. And just hearing someone say that to you, you feel such a relief, because you're like, I'm not crazy. I'm not broken. And there is another person who can tell me that it's going to be okay. No matter how long it takes. I mean, I know it's going to be okay, because this person who knows what she's talking about is telling me that you don't have to live like this. We can find a way.
Yes. And if the first recipe doesn't work, then we change it. I mean, you phoned me the other day, this and this is now going on.
Yes.
Our bodies change. And with hormones, there's no one size fit all. I can put this one on a patch, that one on a pill, that one on a gel. And this might work for you, this might work for you. It is a journey. And that really is my passion, to create a space in saying, please, let's walk the journey together. Your body is still going to change as we get older, and that it's not just one appointment and off you go. You now sorted till you're 51 and in menopause.
Yes.
It's a journey, and I'm also just human, but I need to listen. If you're telling me this is your symptoms, then I must believe you. I'm not in your body to tell you how you must feel, or you're talking nonsense.
Yeah.
It's, as a healthcare provider, you need to listen to your patient and explain, because you already went on ChatGPT before you came to see me. So, okay, good. ChatGPT is right, but let's put the human and the person behind it and explain it, and just make it a bit broader than what just Google or
unpack it
ChatGPT
and
says.
personalize it a bit. Yes.
I think
That's the time we live in.
Yeah, exactly. I think a huge part of the frustration for the both of us was being exposed to this. We spoke in our last episode about the cultural awareness that's cropping up around perimenopause and midlife, and this kind of gap between being postpartum and suddenly being menopausal, there's a good 15, maybe even 20 years between that for some women. Can be 10 years, can be 20 years. There's this gap in our healthcare, and often when I brought it up, say with my personal GP, my family GP, and my gynecologist or anyone else, and I brought up potential perimenopause, it was like, how old are you? No, you're too young. And you also felt that. But when I look at the symptoms you experienced when you were 38 and when I turned 38, I'm not saying each age is particular, and I look at my friends who have not had children, so it's not a postpartum thing, there is a shift.
There are parallels, yes, in each one's story.
Would you agree that firstly there is this gap in information that we almost don't have a name for it? If it's not yet perimenopause, there's a different gap.
Yeah, there's a little bit of a limbo that you're in.
Perimenopause.
Yeah, that's what it feels like to me. Because the body is fluid, because the changes are going to be so gradual.
And there are hormonal shifts, in your body. Like also I had I put everything down to the cyst that I had before I went to see you, 2021, I think it was. I had an ovarian cyst that caused the torsioned ovary. So when I felt painful ovulation and things like that, I kind of thought, okay, well, that must have been the cyst. The cyst is gone now, so I should be fine. But because that happened to me, I became pedantic about regular checkups and regular asking of questions, Whereas before, I would never have asked those questions. Even the extent to which you ask questions, I want my blood tests done, I would never have insisted, let's do my bloods. If the doctor said, you need a pill, okay, cool, I'll take the pill and off I go, So it depends from person to person. So I think it's good that we're talking about it.
Sorry to interrupt. It's important that if you, as a healthcare provider, if you tell your patient, no, I don't think it's necessary to do bloods, explain why. Because, for example, as you spoke and said, I want baseline bloods, then I want bloods later. So then I'll tell you, let's do baseline, but not later when you're on the pill, because then I'm just checking the pill. I'm not checking your own hormones. So I'm not going to waste your money to do bloods when you're on the pill. So just explain. And that already just...
that's exactly what happened for me with you last week, actually,
yes.
because I had a question. I was like, something's not right. I'm on a pill, but I'm still having irregularities with my period. I know we said 3 months, I need to go do more bloods. I'm on the pill now. It's been 4 months. What do we do? And I'm glad I called you, because I was just going to go do the same bloods and send it to you. But something in my gut said, let's just ask Louisa what she thinks. And she said, there's no point in doing your estrogen and progesterone, Charlene, because it's just going to show me that you're on the pill. Let's do X, Y, and Z. And let's maybe change your pill because that one doesn't seem to be working for you. So I agree with you. The fact that you explained that to me made me feel such comfort.
Yeah, I think I'm happy to acknowledge that I'm not a doctor. I never went through that training. I can go on Google as much as I want to, but I'm also not an idiot. And I want to know what's going on in my body, as I said. Like, I feel passionately about that. So another thing that I'm really curious about is there a pattern that makes it normal? We know that if we look at gestation, between so many weeks and so many weeks, baby looks like this. Between so many weeks and so many weeks, baby looks like this. Is there a similar pattern for women and the shift in hormones as we gear up into perimenopause?
I just invented that. I don't think that's...
Don't quote me on this.
No.
I think we're coining it, guys. We're coining it, because there is...
better start with a study.
Yeah.
The South African Broadcasting Association is going to be knocking on our door here. We're going to get cancelled.
There's a gap, and I want to name the gap. I want more information on that. And I was told, oh, Sam, you're postpartum. And I'm like, my postpartum, my single friends who have not had kids are seeing the same things. Why? I want to know. So is there, can we normalize these things? I don't know. Are there symptoms in your 20s, early 30s, later 30s, early 40s, etc., that show a hallmark of quote unquote normality.
Did you want to add something?
No, I was
heard
just thinking because you were saying that as you get older, your number of eggs reduce.
Yeah.
And so there's a decline. And the decline in those eggs affects the pituitary gland and what it tells the body.
Yes.
And so that's why it's directly related to age. And obviously it has to do with genetics a lot, because typically what your gran or your mom or whoever went through
Yes. Yeah, that's
genetically
important.
would play into that.
Yeah. Look, I think very important for women, everybody's story is different. And some women, we spoke about this before we started recording, that some women don't have any of these symptoms. They go through menopause. I had someone the other day that came to see me because she wanted to ask me, is there something wrong with her that she doesn't feel menopausal symptoms? Because social media and her friends, that's all they talk about. And I had to reassure her, you're just very lucky.
Yes, just enjoy it.
Just be thankful.
Yes.
But we discussed other benefits of HRT, which you don't necessarily feel, but there's benefit of going on it. I don't think there's really data on saying this word that we now invented with perimenopause. But I think what is important, again, women should listen to their bodies, and then your doctor should listen to what you're saying, because there isn't a thing as you're too young to be in perimenopause. There's something like premature menopause. The youngest woman I've diagnosed with proper menopause was in her 30s.
Oh my hat.
So that's premature. So you can't.
So like
come
her
and
period
sit-
stopped. So it's the
Wow.
first day after.
She's like, am I pregnant? What the hell is going on?
So
But I also have hot
12
flashes.
months and one day is your period didn't arrive, and that's when you're in menopause.
Yes, but obviously the symptoms can start before then.
Before that, yes.
Like, so she's like, am I pregnant? I'm sure I'm pregnant, but I don't know. I don't think I can be pregnant. But I have no periods, I have hot flushes. So listen to your body, listen to your patient,
Yes.
and do the bloods. Don't have this idea of, yes, you're 38, it's theoretically impossible that you're in perimenopause. No, because perimenopause can be up to 10 years before menopause. You can experience those symptoms. So I do believe that things start to change slowly, and then you start to see it in the bloods. Again, I don't know how scientific that is, but it's basically what we see in practice with some women. Obviously not everybody, because everybody's journey is different. But that's the take-home message. If you feel something's not right, go to your doctor. And I also want to say that, yes, we check hormones, but holistically also check thyroid function and your iron levels and your vitamin D and your B12, all the metabolism and endocrine things, I can say, because sometimes it's just a massive iron deficiency and you feel like you're anxious all the time, you're tired all the time.
Which I also had.
Yes, or thyroid disorder because you feel hot all the time or you feel cold all the time. You just don't have a libido. Your periods are irregular. So again, it is holistic. We are talking of perimenopause today, but you also need to just think of those things as well, that it can be.
Okay.
Yeah.
Okay. That's good. I was thinking while we were talking now about how holistic it is and kind of how broad it is. What would your advice be to listeners in terms of who do you go and see? Obviously, come see me or find a my sexual health specialist. But if you don't know or there isn't somebody near you and you're just a layman, like I said to Sam, who do I go and see? What is the first port of call? Go to your GP.
I would say that a GP is a good place to start because generally we look at things holistically. It's our personalities. And the thing is, if you feel you haven't been heard, like you both felt you need to look further than the first practitioner that you saw, you'll know. But also, let's say you start with an endocrinologist. Yes, they could probably see perimenopause, low testosterone, low iron, whatever the situation is. Let's say the endocrinologist feels, sure, okay, there's now more sexual health related things that I don't feel comfortable in treating, then they should also refer. For example, I can't do everything gynaes do. So postmenopausal women that keep on bleeding, doesn't matter what HRT I put them on, I tell them, now you go to the gynae, because now I think you need either a scrape or something, because now what I'm doing. So we should also know, okay, I can help with this, but now I also need to refer. So we are all in a team. Where to start? I would probably say GP. Again, if it's just a specific concern, like let's say just your sexual health, then obviously you'll look for someone that's doing sexual health. I really hope, and I do believe there is a move towards all doctors actually just getting more sexual health education. Because like I said earlier, it really doesn't matter what specialty you are, it always comes out in a consult. But if you're not comfortable in talking about it, or you just don't know, I mean, I also don't know everything. If there's something that I'm not comfortable with, then I'll refer. Then actually just refer to someone with a bit of extra sexual health knowledge. Yeah.
I think the key here is for doctors also to know their limits firstly, and not to work in silos. If you know you have a team backing you. I'm very happily spoke with my GP about going to see you, and she was like, I must do that. And I felt like I always feel like she has my back.
Good.
And I feel like even though you guys haven't spoken, at some point you might, you know, and I know that my GP has also spoken with my gynecologist, and with everybody working together, my GP's also spoken with so I've got a great GP by the sounds of it now that I'm saying it out loud. She's happy to speak with everybody and foster this holistic healthcare that all doctors don't operate in silos. I think that's important.
Yes.
On that note, it is a bit of a digression, but I do think that we need to chat about treatment options.
Yes.
And it appears that not all doctors agree because of the studies out there on HRT. So firstly, before we go into the controversy around HRT, let's chat about what the treatment options are when you're starting to head into perimenopause. I mean, my eggs came out viable. They're still there and want to be fertilized. And I'm like, no, thank you. But we'll keep them for now. So that was not an option plan for me. For Charlene, it's looking a little bit different, as I understand it. HRT, there's creams, there's
patches,
lubricants, there's patches, there's
tablets,
oral medication, there's injections, right? No injections, that's contraceptives.
Yes.
So we're looking at key difference between contraceptives and hormone replacement therapy.
Yes.
What are the solutions? Maybe should we start with the symptoms? What are the symptoms and what are the solutions for those symptoms? I know I'm throwing a lot at you now.
I'll try and break it down. Okay, let's start with perimenopause. So I've already said that during perimenopause, it's the fluctuation of hormones that if you are someone that's sensitive to how your hormones fluctuate, you will feel the symptoms. We're not all the same. The most important thing is that to remember, except if you were sterilized or had a hysterectomy, or if your partner or husband had a vasectomy, that you can still fall pregnant. Okay, so that's probably the first question I always ask if I'm going to treat someone for perimenopause. Do you need a contraceptive? Because you can still fall pregnant. And women don't believe me. Then they sit there, they're 50, they still have eggs, high estrogen, not high, but let's say enough. They're not in menopause yet. Then say, you can still fall pregnant. And some of them will not believe it. But anyway, you can still fall pregnant in perimenopause. So you don't want to take that chance. So the aim of whatever we want to treat with in perimenopause is to help with those fluctuations. So either we opt for a pill that gives, there's one with contraceptive or with that's not a contraceptive, that gives you the same dosage of hormone every day, so that it doesn't do this. Then if you do patch or gel or pill combination, you want to almost mimic the natural cycle. So progesterone a bit low in the beginning, then it goes up. So it's the two options. Let me go back to the symptoms. Okay. Then we'll chat about the patch and gel and those
So
things.
we're looking at just to bring in some terminology, you're
Yes.
talking about the difference between quadriphasic, right, and monophasic. Those monophasic levels are what gives you the same dose every time, and
Yes.
quadriphasic is what mimics the
Yes.
cycle.
Yes. So a phasic or biphasic or triphasic or whatever option you go is more mimicking the natural cycle, whereas something with the same dose every day and then you just withdraw the hormones, the placebo pills, so that you get your period. So we can mimic the cycle with patches as well, and we can mimic the cycle with the combination of estrogen gel with a progesterone tablet. That's basically your options. Not all of it is a contraceptive, so you should check with your doctor about that. Then, or you can even do an IUD, a Mirena, for example. With Mirena is also indicated for postmenopausal women to protect the womb, because then you need progesterone. And then just add, for example, then you can decide an estrogen patch or gel or pill. So there's quite a few combinations that you can look at. Very personalized, because it's about your symptoms. It's about what you feel comfortable with.
Yes.
Because some women, I tell them let's say the gel and the tablet at night is very safe option. It won't cause breast cancer. They're like, but I don't want to put a gel on every day, or I don't want a patch because I'll forget to change it. So it's also, I always ask, what do you rather prefer a pill? If you're used to taking a blood pressure pill every day, let's just
Add another pill.
gooi the hormone pill in there as well. So that also plays a role. Let's go back to symptoms. So all the symptoms that we typically say menopausal symptoms can already start in perimenopause. So I like to break it down as to which hormone, as it drops or fluctuates, causes which symptoms. Let's start with estrogen. So as the estrogen fluctuates or drops, it's the hot flashes, brain fog, joint pains. I have seen women that a doctor thought they have arthritis or rheumatoid arthritis or osteoarthritis, but meanwhile it was just perimenopause. So again, I think doctors should just always keep at the back of their minds, there's hormones involved in women, men as well, because testosterone, that's a topic for another day, but can make men feel just as crap as women feel when they're going through menopause, a low testosterone. Okay, so joint pains, then the vaginal dryness is from the estrogen that drops, where you can also feel it in your skin. So the elasticity and the puffiness of
Everything just
the
feels
skin and the vagina
dry and yuck.
goes down. Yeah.
Dry skin causes itchiness, so you feel
Yes.
itchy.
Yes.
Yeah.
What did I miss now with estrogen? Did I say hot flushes?
Yes.
Yeah. Oh, more inflammation. So the way your body holds onto fat is different. So that's where women can start saying, I am gaining weight around my belly.
That was a big one that I forgot to mention.
Yes.
Like I was just weird weight gain, and nothing else I was doing that would usually keep my weight stable was working.
Yeah.
Yeah.
So, and typically we'll say around
Midriff,
the belly.
yeah.
Stubborn belly fat.
Yes, the
which we
menopause
will,
belly.
just also to throw forward, we will be discussing that as well.
Yes.
We will be discussing.
We're going to cover all of it.
We're going to cover
people.
all of it in this
Great.
series.
We're
Very
doing
excited.
a deep dive on this.
looking at exercise and looking at weight training and that tiresome fupa that we speak about. But I digress. Please carry on.
Okay, midriff weight gain.
Yes, and mood changes.
Yes.
Okay, so usually what women will say, and I think that's what you also experience, nothing really happened, but you just feel down and worthless and sort of a hopeless feeling. And you can't pinpoint as to something that necessarily happened that made you feel that way. I think that's the main things with estrogen. If I miss something, please add. Progesterone. Two main things there: insomnia, so struggling to sleep, and anxiety. Okay. And those women will often say, yes, I wake up 3 o'clock from a night sweat as well, but
Then you have this
I
like
also
feeling
feel
in your chest. Yes.
so anxious, and on top of it, I can't sleep. So obviously you need to have progesterone as part of your HRT if you still have a womb. But if you don't have a womb, traditionally you don't get progesterone. But if I see someone that really suffers from those symptoms, then I give them progesterone as well, whether they not have a womb.
Interesting, yeah.
I just give it because they feel better. And there's no reason as to not to give it. So you can ask that from your doctor. Then testosterone is the libido. So sexual desire. Then you can also say, and this is sort of off-label, but you also the loss of muscle. So I do have women that I give testosterone. They're not, let's say, bothered by their libido. They're single, but they just feel better. Their mood feels better. Their body feels better when they take testosterone. So testosterone is that, and then also it can mess with your orgasms. So how sensitive you are down there.
Okay.
If the testosterone is low. So
Don't mess with my
testosterone-
fucking orgasm.
Exactly. I was just going to say, don't take that from me.
With my
Good Lord.
orgasm. What are you doing?
Testosterone has a lot to do with sexual function,
That is an interesting
but
one.
also mood and muscles.
That's a very interesting point that you made, Louisa, because I did not, in my initial discussion with you, think to bring this up. But I had low libido, and the orgasms just were, when I did have an orgasm, it was nothing to write home about. And it wasn't because due to lack of trying, let me just say that. My husband's very effective and generous, I will say that. It was just, the orgasms felt different, less intense, less enjoyable kind of thing. And it didn't dawn on me until you just mentioned that. Okay, so that's interesting.
Yeah. And testosterone we give in the form of a cream, bioidentical cream. I don't like injections for women with testosterone because the release of it is not, can I say, the same every day. So it fluctuates a bit. So personally, I won't inject a woman with testosterone.
Yeah.
I will do the cream.
Dr. Louisa, we are going to have to wrap up soon, and we've got so much to get through. But I really do want to touch on, you spoke about bioidentical testosterone that you will apply. That makes me think of doing some reading, seeing reels. I mean, the reels, Charlene and I, our Instagram is just a buzz with perimenopause and menopause content.
Yeah, the
That is
algorithm is like...
That is our echo chamber. There's a lot. And there's been a few that bang on about the difference between bioidentical and synthetic HRT or estrogen. You can correct me on my terminology. And then the risk of cancer. I think that is a big concern for a lot of women as these terms and these treatments are bandied about in this echo chamber. So can you clarify for us, firstly, what is the difference between bioidentical and synthetic hormones? And then what's the big story with cancer risk?
Okay, so yeah, that's a very important question because still women don't want to take HRT because of that risk. Look, we are getting more and more data on certain HRT, and obviously we're going more for the natural form, even if it's not exactly bioidentical, but a natural form of estrogen and progesterone that has been shown not to increase risk for breast cancer. Can I say this? So if you see a patient, you'll discuss, what is your family history and all that. But you hear of people that get breast cancer even with no family history of breast cancer. So personally, I will always go for the more natural forms, okay? Not just breast cancer risk, but also blood clotting risk. The thing where there's been proven a little bit of risk with increased risk for breast cancer is synthetic progesterones. So the estrogen is not really the culprit, but the synthetic progesterones, okay?
Okay.
In saying estrogen is not the culprit, means that in general, there's other risks also for breast cancer. So if you have always been premenopausal, more estrogen dominant, and you have a lot of inflammation in your body, smoking, obesity, all those things, an inactive lifestyle increases the risk for breast cancer. So the move is more towards your natural and micronized progesterones. that is safer. And the studies show that there isn't an increase with breast cancer with those medications.
Okay.
So educate yourself and ask your doctor about it when you go for your HRT prescription.
Okay.
So there are safe options, and that has been proven with now numerous studies coming out that it is safe.
Okay.
We are still a bit scared if you yourself has had breast cancer, then we won't give HRT. Then we try and manage the symptoms differently.
Okay.
Manage the symptom and not the cause.
And what if you sort of have the BRCA gene and you have a family history of just like both grandmothers, your sister, your mother, every woman in your family has had breast cancer, and you've got the BRCA, you've got the BRCA gene, and it's all signs point to, I need to be doing a mammogram twice a year. You know, would that then be cause for concern to go ahead with HRT?
Yeah, I mean, yes, I think it will be, but also then you will opt for the things that have been proven not to increase your risk. But now you're already sitting with someone that is at risk, just genetically. So
Yes.
taking hormones out of the equation,
Yeah.
genetically, yes, and that's where you have to really sit with that patient and decide, this is okay, let's go for the hormones, but you have to have your mammogram, let's say twice a year.
Okay.
But
And I suppose also some
prescribe the
symptoms
stuff
might
that
be
doesn't increase the risk.
some symptoms might be worse than others. So the patient in that case might be like, okay, this bugs me, but it doesn't bug me that badly. But
Yes.
this bugs me a great deal.
Yes,
Yeah.
and then you'll maybe, okay, let's then rather treat that symptom that bugs you so much. But yes, there are things that is more safe
Okay.
than others.
Okay.
What would your underlying message be to women experiencing this shift? We've coined it now, guys. Pre-perimenopausal. Or I'm so fascinated by the woman who came to you and was experiencing no symptoms and was concerned about that because of how much. I'm glad that we're talking about it enough for
Yes.
women to be like, is something wrong with me?
Should I be having these things and I'm not?
I'm happy for this generation of women that we are speaking up about our discomfort and prioritizing ourselves, and that we're seeing healthcare professionals that increasingly are listening to our concerns. I think the age of information, it has its many downsides, but I think the age of information is pushing doctors to and medical professionals to really step up in terms of the human element that you spoke about.
Yeah.
So what would your underlying message be for a woman who feels just this nagging that something's not right?
Listen to your body. And if the doctor doesn't listen to you, go look for someone until you find someone that listens to you.
Okay.
I love this new age of affirmative healthcare. I love what you're doing, and we're so grateful to have you in our lives and to have had your care. It's made a huge difference, obviously, in both mine and Charlene's lives. And we're really grateful to have you on The Great Equalizer.
We're going to link our listeners up to My Sexual Health Network, links, telephone numbers, wherever they can reach out to, so they can see if there's a sexual health specialist in their area, if they do want to reach out.
Yeah, and we also do online consultations.
Yes.
Yeah.
Amazing. Well, Dr. Louisa, thank you so much for joining us on The Great
ladies.
Equalizer.
Keep up the good work.
Well, Charlene, how about we keep talking?
Yes, we will. I mean, talking is a bit of, I think it's my toxic trait. I can't stop talking.
I'll take it.
But listeners, you have to stay tuned, because our next installment of TGE Talks, we will be chatting about sex and how aging and hormones and perimenopause impacts on libido, desire, and just interpersonal relationships, all of those things that I guess you think about and experience, but who do you talk to about them? So we're going to be doing a deep dive on that.
Please, if you have a question or a comment, DM us a voice note on Instagram or record one on your phone and pop us an email. We're at info@thegreatequalizer.co.za. If you have a question for a healthcare professional, we're going to be talking to many more doctors in this series, all my sexual health affiliated doctors, including Dr. Alna Rudolph herself. So we don't have the answers, but we're going to be talking to people who do.
Exactly. And feel free to like and subscribe to any of our channels, Spotify, wherever you get your podcast, and also on YouTube. And then that way you'll get notified of when the next episode is available and you can tune in and you don't miss anything.
And so, Charlene, I think that's it for this week.
Yes.
Until next time,
keep your mom game strong.